how affordable is this for the private patient? You're talking about $100 for a virus load? $50? About 50. Okay. Yeah, no, that's helpful to. And do any of you get resistance testing for difficult patients? I see 1, 2, 3, 4. So it's multiplying. Great. No, that gives us some valuable information about where you guys are.
Sir, my question is about resistance. As compliance is very poor in our patients, and that is the main cause of resistance. So your data may be different and Indian data may be different. What do you suggest about the resistance? Because failure is also going up.
So how do we deal with resistance? You say it's increasing. So
I think you're worried about adherence. Yeah. Well, if adherence is really poor, then you don't have a problem with resistance. That's the good news. The bad news is if adherence is really poor, you're going to have a very high virus load and very transmissible virus. And I don't know, Rami, do you want to?
So tomorrow when we do sort of what's new in resistance, I'll review some papers from India actually showing that the resistance levels are very high. And so I agree with Dr. Katzenstein that if there was no treatment adherence, then you won't see any resistance. The fact that resistance is very high, up to 90% of the people, means that they're at least taking some of the medications. So I agree with you that adherence is a huge problem, but it's maybe taking it not in the right way or taking it with treatment interruptions as opposed to not taking it, and that definitely should be addressed.
Is there a role for directly observed therapy for HIV treatment, just like theoretically people are supposed to be using DOTS for TB treatment?
On treatment, have any of you had experience with that, or are we seeing any tools for adherence to try and increase? Yep, no, I think DOTS, as it's been used in TB, is not directly applicable, although a lot of people have tried short course intensive DOTS, particularly for difficult to manage patients. But I guess I would encourage people to think about the possibilities for using all these tools that now keep patients in touch with one another. But yes, it's good to hear from someone who's actually doing it.
Actually, as per my perspective, the people, those who are non-adhering for treatment, or it's a one way of failure of healthcare providers. If somebody has to die, they will commit suicide. They will not die slowly. So believe us, we don't want to leave treatment. There is a big question mark on the quality of health services which is given, is the big question mark. The adherence counseling is not there. The how to manage side effect, that counseling is not there. Treatment counseling is not there at all. There is a big question mark on the quality of counseling. And people, we have one group of people, those who are leaving the treatment because of side effects, and there is one group of people, those who get good quality counseling, they are not even missing one pill, and not even delaying their pill by 1 hour or 10 minutes. So that kind of things are, both things are here present, but that quality of counseling is not present in the. Second thing, the access. The access is still so, like you have to come to AIT center, you have to show your face once in a month. All those things need to be rolled out now. Why we are not giving 6 months medication? Why we are not empowering the patient that person can make sure that that person will take the treatment, and whenever he needs consultation, he will go to doctor or she will go to doctor. But every month I have to show my face and I have to wait there in the AIT center which is going to be crowded day and day by day, day by day.
Thank you. I think maybe one last question on the point of care aspects of diagnostics.
Though, if I could just respond to the last remarks, I think it's very important that you and your fellow patients really form treatment adherence groups in order to interact with each other, because essentially government and the private sector is going to be very good at seeing you in their offices and discussing at great length side effects, but for a price. And I think it's really important that patients begin to inform one another, that you need to, in fact, create information systems at the level of the people who are taking ART, rather than expecting a vertical
Exactly.
sort of
That's what
response.
the program needs to adapt the community-centric model, that community can deliver the treatment, community can do the DBS for viral load or CD4 count, and community can reach to the people. So that access should increase and it should be given by the community.
I think we have one last question here, and then we can wrap up.
Regarding the pre-exposure prophylaxis and like use of PrEP and drug resistance, what is your experience, and is it like we should encourage or not PrEP?
I think the most important thing is to make sure that the patient is not infected before we start PrEP. I think in the majority of the studies that have looked at the connection between resistance and PrEP found that this is what happened, and actually the occurrence of resistance in people who are truly not infected and starting PrEP is extremely low. So I would encourage that to happen first, and if you're sure that the patient is not infected, I would definitely encourage PrEP, which is very important.
Thank you very much.
And, yep.
I think Dr. Priyanka's lecture was very important on psychotherapy. The question was asked about psychotherapy and impact of psychotherapy on stress level of HIV. Also, she did mention on the menopausal sex workers, but it can extend to many people. And I think in whole medical, I think we take it, HIV as a medical problem, but the psychological problems, what they face, are very important to tackle. And I want the audience to go that it's not the doctors who make the HIV patient better, it's also mainly the workers who mainly work on psychotherapy are the ones who make the patient much better. So this is I don't want to take sides of anybody, but this is a true fact, and all of you should have a social worker when you are working with HIV patients.
So I think in the interest of time, we need to wrap up, but if we could all thank our speakers. Yep.
I'd request the chairpersons to kindly present a token of appreciation to the speakers. Dr. Katzenstein. Dr. Madhuri Thakkar. Dr. Barron. Dr. Cantor. I request Dr. Dilip Mathai to kindly give the mementos to the